Hello all, this is Renee. I'm going to be guiding you through the vascular access lecture titled CVCs, PICC, midlines, PIV, HAC, and CLABSI, also affectionately known as the alphabet soup of vascular access. Before we start talking about the different types of intravenous therapy, I just want to explain to you, where do our therapy standards come from? So notice that we usually base most of our hospital policies on the Infusion Nurses Society. They are responsible for publishing best practice standards, and their standards are based on extensive research, literature reviews, and evidence-based practices around the globe. Their last review was published in 2016, where we were able to note quite a few differences and changes in how we practice to prevent CLABSI with central lines. So yeah, hospital policies are based on standards and recommendations that come from a nurses society, which is pretty cool. So let's jump into it. Let's talk about the PIV, the peripheral intravenous access. Why do we choose this route? It's simple, it's easy, it's easily done, it's easily accessible. It's also within the RN scope of practice. An RN can independently place a PIV at any time and as needed. If a physician or a nurse practitioner orders start IV fluids, it is up to the RN to decide what size needle, where are they going to put this, using their critical thinking skills to decide hand placement. Are you right or left-handed? Are we going to the OR? So you might choose a bigger bore needle. Is this because we've had massive loss of fluid? Do we need to infuse fluids fast? Again, we need a bigger vein, a bigger needle possibly. So a lot of things that come into consideration that are within the nurse's scope of practice to make these decisions. You can see the different sizes here. The one on the right, the little tiny yellow one, that is a classic size that we place in neonates or babies. It looks like a classic 24 gauge needle. With these needles, as the number gets smaller, the bore or the diameter gets bigger. So the one on the left-hand side that has like the red plastic on it looks like it could be an 18. So lots of different sizes depending on where you're placing. You can also notice there are different lengths as well. So depending on the patient population you're going to use this on and where you're going to place it, that even might be a 16 gauge, will determine how big and how long that needle is. You can also notice that at the top there's a white tab or button, and that is a part of the safety device that is used to protect you from needle stick. So after you insert your IV, you push the button and it retracts the needle and leaves the plastic catheter behind in the vein. So moving from that picture, typically the nurse is the one who is also responsible for not only the access and how you get in, but the care of that site. So site assessment, very important with a PIV. When you're running fluids, it's running usually at a fairly good rate. And you are responsible for that site assessment, watching to make sure that there's no problems with infiltration, which means the fluid is running into the skin, or extravasation is another word for that. So you want to be assessing your site. Typically in the hospital, you will check at a bare minimum every 1 hour. We use a technique called touch, look, and feel. So you're going to touch the site, making sure there's no pain or swelling. You're going to look at the site, make sure there's no redness or swelling that you can see, and you're going to compare. The TLC is compare. You're going to compare. If it's in one hand, you want to compare it with the other hand to see if you see any noticeable difference or change that might reflect the infusion of fluid into the skin. You're also responsible for the tubing and dressing changes as well. Classic orders are tubing changes every 96 hours for maintenance fluids, and same with dressing changes. And that's because biofilm builds up in tubing, and we can't let the tubing run forever. But as biofilm builds up inside the tubings, it becomes a great medium for growth. So tubings are changed no longer than every 96 hours. Other fluids may be changed more frequently. If we're using parenteral nutrition, then there are a lot of things in there can grow bacteria very easily. So those tubings are changed every 24 hours. So when you're in the hospital setting, you will be following your hospital's guidelines for tubing and dressing changes. You'll notice on the tubings there will be filters. There are various pumps that are used to deliver fluids. Back in the day when I first started as a nurse, you only used a fluid infusion pump for critical medications and blood. You didn't use it just for any old IV. Now everyone has their IV placed on a pump. There are caps, needleless connectors. When we refer to caps, you'll notice on IV tubings there will be little green caps. Some places use blue caps. The green ones are called Curos. The caps are protective. They are not bacteriostatic at all, but they're more of a barrier or protection for the injection ports. So if you are working with a nurse and when she takes off the cap, if she's not cleaning the injection port with either CHG or an alcohol wipe, she's not following recommended guidelines. So those caps are just to be protective barriers. Needleless connectors, those are placed on the ends of IVs so that we can hook up without using needles. Back in the day before we had them, you had to put a needle on the end of a catheter and then you would insert it into an injection port and you actually taped it to the IV so that the needle didn't come out. So we're really thankful to have needleless connectors. When do we decide that a peripheral intravenous catheter is not what we need to be working with and we need something that's a little bigger like a central venous catheter? When we're going to use super hypertonic solutions. If we're going to do some significant electrolyte replacement, we usually don't like to give calcium in a peripheral IV. Calcium, if it gets into the skin, can actually cause skin to turn dark and die and slough off, and you can create scarring. So we're really particular about certain medications if they're being run at a very high rate and a very high concentration that we switch to something that's a little bit bigger vein. Vasopressors, usually we try to run those a little more centrally, and chemotherapy and vesicant. And a vesicant, again, is any kind of fluid that we would be running into that vein that could cause some kind of painful damage to the skin. Choosing a vein for a PIV infusion. So you've got your upper extremities are usually your best sites. For babies that are not walking, we will use the feet and the legs right around the ankles. The saphenous is a golden, fabulous IV site for neonates. It's a nice big fat vein and it tends to stay exactly anatomically where it should. So even if you can't see it, you can get to it. We really want you to try to use the non-dominant arm when you are looking for sites. You want to avoid using compromised upper extremities. You don't want to start an IV on the same arm that has had an infiltrate or an extravasation. You try to use the other side, or you go above the infiltrate or extravasation. You would never, if somebody had a fractured clavicle, you wouldn't use that arm that was on the same side as the fractured clavicle. If there's bruising, you want to stay away from it. Also, if they have if they're diabetic and they are getting dialysis and they have shunt that they use for dialysis, you're not going to start an IV there. You don't use antecubital veins if another vein is available, because if you use the antecubital, which is in the inner aspect of your elbow, your patient can't bend their arm. So if you need them to ambulate and use their arms, or if you need them to have some access with that arm, to put something in their anticube is not necessarily the best idea. So you have to be really, use your critical thinking skills and think really hard about where and how you place this, okay? Phlebitis versus infiltration, excuse my mispronunciation. So phlebitis is an inflammation of a vein commonly caused by chemical or mechanical irritation. And infiltration is when you have a leakage of the fluid out of the vessel and into the skin. So sometimes IVs get dislodged with movement, they migrate, so infiltration is always a concern and something to be watching out for. Phlebitis can be okay as long as it doesn't get increased. In most organizations, there is a phlebitis and infiltration scoring rubric that you can use, and it helps you determine if the phlebitis is severe enough to go ahead and pull the IV, because sometimes all it is irritation. Sometimes it means there's infection, especially if it gets redder and starts to spread up the path of the vein. Sometimes if it's just an irritation, we can decrease that effort by a little ice pack, slowing down the infusion. There are some medications that are notoriously inflammatory and uncomfortable. Penicillin in a peripheral IV is well known to be a very painful and irritating infusion. This is a picture of Linda's hand. She had an IV that infiltrated on her. Can you see the swelling there? There's a little redness at the site where it was inserted, but her hand is completely swollen up from the IV fluids not being able to infuse into going up her hand. They infused into her skin. So let's move on to the CVC, or the central venous catheter. There are tunneled and non-tunneled. You will note the location of where they're at, where the tip of the catheter is. It's usually in the superior vena cava, so not in the actual heart. We don't want it migrating into the heart, but just above. Okay, why do we use CVCs? These are used to, when we are going to infuse something that's very either long-term or possibly very irritating, we will use the CVC. Really important usage would be for chemotherapy. And the reason is that vein, that part of the vein, very big, a lot of fluid rushing by, things dilute up really quickly. Really great access point. They don't tend to migrate too much. They tend to stay where they're supposed to be. Tunneled catheters are known also as Hickmans or Broviacs. They are placed surgically under general anesthesia. They are usually cuffed to prevent them from coming out or moving, and they are long-term. We can pretty much do anything there. Non-tunneled CVCs are short-term, usually 5 to 7 days. They usually they will go into the internal jugular or the subclavian. Sometimes we'll put them in the femoral. This one can be done in an ICU, cath lab, interventional radiology, the OR. It's done aseptically, and many times we will transduce it so we get central venous pressure. It's another way of monitoring a patient pressure. So, how they are similar, tunneled and non-tunneled. The tip ends up in the superior vena cava usually. The similar uses, one though, like I said, is usually more short-term than the other. We will flush with a 10 ml syringe, nothing smaller than that, and push pause per policy. So a lot of times you'll push, stop, kind of a pulsating push. to flush. How do we care for this site and how do we access it? You will always use aseptic technique, so sterile gloves. You'll probably have a mask. You might even have a cap on and possibly a sterile gown when you're in this area. We don't change the dressing every 96 hours. We let the dressing go 7 days. Connectors, the needleless connectors will be changed every 96 hours though, but a dressing, because when we change the dressing, that is a sterile technique. The less we open it, the better. So evidence tells us that every 7 days is totally acceptable. Whenever you give a medication through these IVs or give blood, you want to make sure that you are flushing the ports adequately afterwards. Otherwise, they tend to get clogged up. The PICC line. So peripherally inserted central catheter. So this is used in many times when you have difficult peripheral IV access. You're going to be on long-term antibiotics. Possibly in consequence with frequent blood sampling. Common insertion sites in adults can be the anacube. It can also be real common to put one in the brachial artery is another access point. Sometimes they'll start down in the hand too, but that's kind of a long way to go. When we put these in babies, many times we'll put these in premature babies. We try not to go below the diaper area just because those IVs can tend to get a little on the dirty side with babies who have diaper or needs or incontinent, I guess you could say. So we tend to try to go above the diaper area when we insert it, and many times we'll put it in their inner arm and then work it all the way up. The tip ends up in the superior vena cava or the inferior vena cava. It can be placed midline, so not centrally. It can be placed a little farther down, but that can limit what you can infuse. So midline placement does not account for a bigger vein and big fast rush of body fluid that's going to dilute it, blood that's going to dilute it. So we really would prefer that it goes to the superior vena cava if at all possible. Also with the PICC line, we tend to be able to put in a line that may have one or more lumens. So that allows us to assign one lumen to fluid, one lumen to antibiotics. And if we have a third lumen, we can use that for blood draws, which is really kind of nice. These are inserted sterilely or aseptically, and this is done usually at the bedside under local anesthesia. Access and care is the same as CVCs. You're going to access this aseptically. You are going to change dressings aseptically, and you will be all geared up when you do this. HACs and CLABSI. Just a review on what a HAC is. Hospital-acquired conditions is what HAC stands for. These are the things that we do to our patients or happen to our patients when they're within our care. So we know that we can do things that will help prevent these from happening. And you'll know one of the practices that you're going to run into is that there are multiple practices that can help prevent these HACs, and they are put together in what we call bundles. So there's a VAP bundle, there's a HAPI bundle, there's a CAUTI bundle, there's a CLABSI bundle. So a bundle is basically a group of practices that are evidence-based that have been found that if you do every single solitary one of them all the time in a bundle, you will decrease your HAC likelihood and save your patients from having prolonged stay, more antibiotics, and possibly even being hurt or dying from an infection. CMS, which is Centers for Medicare and Medicaid, recognizes 14 different HACs, and all of these are reportable events. So when we have a true HAC, we have to report it to the California Department of Public Health, and we report to CMS. All the regulatory bodies require us to report all of our HACs. CLABSI is the HAC that is associated with central lines. CLABSI stands for Central Line Associated Bloodstream Infection. The number one defense against a CLABSI is hand hygiene. And at this point in the world today, we are all have become quite proficient at our hand washing. So we've just posted here the WHO's methodology for recommended technique for hand washing. You just basically for sure need to be washing your hands for a minimum of 20 seconds. Other strategies that are used in the CLABSI bundle, example bundle elements, we call them bundle elements, are sterile line changes. So we change our lines sterilely. That means you're all garbed up and wearing sterile gloves when you change the lines. Daily line necessity discussion. So every time there are rounds, we discuss with the provider, do we still need this line? Can we take it out? Scrubbing the hub, 10 to 15 seconds, unless you have a CHG impregnated wipe. When you use CHG impregnated wipes that are in combination with alcohol, you only need to scrub for 5 seconds and let air dry for 5 seconds. If you only have alcohol wipes, you must scrub for 15 seconds and air dry for 15 seconds before you connect to the hub that you've just scrubbed. And the hub is the same thing as the injection port. It's a little rubber port that you'll find on an IV tubing. And then we also do daily CHG bathing. So there are wipes in packages that we can either do the bathing ourselves, or we will have the patients bathe themselves. And daily all over CHG bathing actually is definitely been proven to help decrease your CLABSI rate. We don't do that for babies because CHG can cross through their skin. They have very open skin, and they don't have much keratin to protect them from the CHG. So we're not really sure how much neonates absorb CHG and into their brain. So we do not do CHG with neonates, but pediatric patients and adults for sure. CVAD nursing care. So here's a list of some considerations that you need to think about as you're caring for a patient with central line. First, you have a patient, if you have a patient who has a PIV and they've decided to start a new central line, you cannot take the existing PIV tubing and bag and just transfer it over to the central line. You must start all new central lines with brand new tubing and brand new bags, even if you just started the PIV tubing and bag. We don't want to risk the chance of contamination, so always start any new central line with a new tubing and bag. You want to also ensure that a chest x-ray has been taken after a central line has been placed and prior to any infusion being started. We cannot have anything infusing in that line until we are assured that the line is properly placed. They do use ultrasound to help guide that placement and measurement, and until we are assured by x-ray that it is in the right place, we don't want to start anything going in that line. So high priority is making sure that chest x-ray has been done and been read, and the order says go ahead and start the line. You're going to be changing the dressing at least every 5 to 7 days. Best practice is 7 days. If there happens to be a gauze dressing only, then that will need to be changed every 2 days. The semi-permeable membrane is also known as Tegaderm. That's the brand name. And I really don't think you will run into anyone who doesn't use a Tegaderm dressing. So every 5 to 7 days. You will report to the MD any signs and symptoms of complications, such as pain or tenderness on or near or around the insertion site. When you change the dressing, you're going to be looking for a change in color or skin temperature at or surrounding the insertion site. You're going to watch for edema or swelling and pay attention to see if there's any leakage of fluid or pussy drainage from the site, or bleeding as well. That can be a concern. Or if it even looks like it's been dislodged at any point. So those are the things you'll be looking at as you change your CVAD dressing. Okay, so that's the end of this lecture. Thank you for your time. Look forward to talking to you all on Zoom, and have a great day. See you soon. Bye.